Hi everyone, today I'm doing my leadership presentation about congestive heart failure. Patient handoff will be using iPass, a tool that is utilized to standardize handoff performance to reduce errors and provide improvements in the clinical settings. It is composed of 5 parts: illness severity, patient summary, action list, situational assessment, and synthesis or summary by the receiver. For the first part, our illness severity. Our patient is Mr. Washington. He is a stable patient. He is a full code with no known allergies. The next part is patient summary. Mr. Washington is a 65-year-old African American male who presented to the cardiac rehab center with complaints of fatigue, shortness of breath, fluttering feeling with his heartbeat, and occasional productive cough. He also experiences nocturia about 2 to 3 times a night and has gained 5 pounds in the past week. He has a history of myocardial infarction from the last year and was given a working diagnosis of congestive heart failure based on his presenting symptoms. Continuing with patient summary, we performed additional assessment relevant to diagnosis. It includes as follows: upper and lower extremities are cold and clammy upon touch, cardiovascular findings of murmur over the left fifth intercostal space, an S3 gallop, jugular vein distension was observed or JVD, bilateral pitting edema in the lower extremities measured at +3, and Mr. Washington has weak peripheral pulses. Additional assessments for respiratory system are crackles on bilateral lung bases, slight wheezing upon inspiration, and shallow breaths. GI and GE reveals lack of appetite for about 2 weeks. Initial vital signs upon presenting in the cardiac rehab are as follows: heart rate of 134, blood pressure of 125/80 with a MAP of 106, respirations of 22, temp of 98.7, and O2 sat of 94%. The next part is the action list for patient handoff. We performed several diagnostics. Mr. Washington had to undergo several laboratory and diagnostic assessments to confirm the diagnosis of congestive heart failure. Comprehensive lab analysis and diagnostic procedures are required to determine the cause and severity of heart failure. And the list are the ones that we performed for him. Another part of the action list is the treatment plan. Diagnostic results came back confirming diagnosis of congestive heart failure. Mr. Washington's physician prescribed a diuretic called Lasix to help remove excess fluid and relieve dyspnea. He was also enrolled in a cardiac rehabilitation program that focuses on patient assessment and nutritional counseling, weight management, blood pressure, lipids, psychosocial and physical activity counseling, and exercise training. Cardiac rehabilitation optimizes cardiovascular risk reduction, reduces disability, and encourage active and healthy lifestyle and maintain these healthy habits. Part of the patient handoff is our action list continuous monitoring. And Mr. Washington went back for a follow up and reported a decrease in weight. He has been adhering to his medication regimen and was able to walk further in a treadmill. He has not been urinating at night but still complains of a fluttering feeling in his chest. During this visit, Mr. Washington's blood pressure is elevated at 140/88. The next part of the patient handoff is the situational awareness and contingency planning. Mr. Washington will continue with cardiorespiratory monitoring, cardiac rehabilitation, and medication adherence. Due to new health complaints, Mr. Washington is now prescribed with captopril, an ACE inhibitor, to help manage his cardiovascular symptoms. Suggested interventions to be planned is a referral to the cardiologist for further evaluation and keeping his appointment with his physician in 2 weeks for monitoring. The last part for patient handoff is synthesis or summary. Mr. Washington is a 65-year-old African American male who presented to the cardiac rehab center with complaints of shortness of breath and dyspnea, fluttering feeling in chest, and occasional productive cough. He also experienced nocturia and weight gain of 5 pounds in a week and fatigue. He was diagnosed with congestive heart failure and was referred to a cardiac rehabilitation program. He was also prescribed with Lasix and an additional medication of ACE inhibitor for blood pressure management called Captopril. He is in continuous activity monitoring. He is scheduled for physician consult in 2 weeks. Recommendations for interventions to be implemented includes referral to a cardiologist, symptomatic management such as oxygen therapy for dyspnea, continuous monitoring to prevent side effects of medications such as electrolyte imbalance from Lasix, and possible interaction between Lasix and captopril such as a risk for hypotension. The next part of our presentation is for social, cultural, and spiritual care planning that will be analyzed to provide patient centered care for Mr. Washington. Like all cultures, religion, family, lifestyle, and communication are the areas where the uniqueness of the African American culture is most evident. Family is the center of the African American community. Immediate family may share medical decisions with the patient. They have a strong sense of shared community. Churches are considered a strong social and religious force of unity. Majority of African Americans consider religion as an essential part of their daily lives. Many seek spiritual healers prior to going to the hospital. Home remedies are prevalent, and many African Americans believe that spiritual imbalance can cause diseases. A lot of them refuse to use opioids for pain management due to social stigma. Several social factors known as social determinants to health put the African American community at risk for health disparities. It affects Mr. Washington's access and ability to afford health care. African Americans have cultural and historical factors that contribute to present behaviors towards lifestyle and medical providers. Apprehensions toward healthcare professionals is observable and historically rooted to mistreatments in the past. Poverty and illiteracy can affect decisions that lead to healthcare, such as poor dietary choices due to financial issues. Illiteracy can also cause poor understanding between healthcare providers and the patient. Embarrassment is fairly common and may cause the patient to hide limited health understanding by not asking questions. Some of the best practices to utilize in providing care for Mr. Washington with special consideration with his social, cultural, and spiritual care involves different aspects. First, healthcare providers need to establish a trusting relationship through a patient centered approach. This helps eliminate barriers and explore the patient's preferences via effective and open communication. Next, through established trusting relationship, cultural understanding and humility can be enhanced and individualized assessments can be performed. Assess preference in religion, dietary choices, health literacy, and lifestyle and behaviors toward medical procedures. FICA is a tool utilized to assess spirituality and decisions made through faith. Dietary choices can be assessed by making a food record that can keep track on the patient's food choices. Allowing the patient to ask questions during conversations about health can help determine the depth of the patient's understanding regarding the health plan. After collecting data about the patient, we can now implement an individualized care. To begin with, we can incorporate the principles of the patient's faith traditions into the treatment plan to promote hope and functional way to deal with illnesses. To address physiological aspects of the disease, we can change modifiable risk factors such as dietary choices. African Americans tend to have recipes high in fat and sodium, which is detrimental to Mr. Washington's health. To provide a patient-centered approach, we can gradually modify recipes by reducing sodium, fat, and sugar based on his satiety. In that way, dietary restrictions brought by illnesses can be accommodated. In addition, low health literacy can be combated by a teach-back method which engages the patient's understanding of the health treatment plan. Allowing Mr. Washington to answer questions that gauges his understanding of the treatment plan can assist us in determining what needs to be reinforced for better understanding. Next part of the presentation is disease analysis of congestive heart failure, where we will discuss epidemiology, pathophysiology, signs and symptoms, diagnostic assessments, and treatments. Congestive heart failure is a disorder that results from a cardiac dysfunction that impairs ventricular filling, resulting to pulmonary congestion. Millions of people manifested heart failure in the United States within the past decade. Current statistics from Global Health Data Exchange Registry states there is about 64.34 million cases worldwide. Incidence of heart failure is the most prevalent among African Americans, people of advanced age, younger population that are obese, and women. Congestive heart failure, or CHF, is formerly known as left-sided heart failure. It can be caused by structural or functional abnormalities and other factors, such as blockage to the heart's blood supply caused by coronary artery diseases or necrosis of cardiac muscle from myocardial infarction. It may also be caused by chronic conditions such as hypertension, diabetes mellitus, valvular disorders, uncontrolled arrhythmia, or congenital disorders. When these abnormalities trigger a hypoperfusion event, compensatory mechanisms are activated. Some of the most common mechanisms are the sympathetic nervous system activation, the renin-angiotensin-aldosterone activation, or immune responses that are activated to accommodate alterations in cardiac output to meet perfusion demands and increase systemic circulation. These compensatory mechanisms are often triggered due to decreased tissue perfusion such as that of a myocardial infarction. Once circulation is compromised, congestive heart failure occurs. Pulmonary symptoms occur due to the heart's inability to put the blood back into systemic circulation, causing congestion in the pulmonary circulation. Most common signs and symptoms are complaints of shortness of breath, orthopnea, and cough. The patient may also report chest pain and palpitations. Fatigue and anorexia is common. Jugular vein distension is a classical finding in patients with heart failure. For severe cases, peripheral edema may be noted. Several diagnostic assessment needs to be obtained to have a comprehensive information regarding the patient's comprehensive history. For lab assessments, we perform CBCs, CMPs, cardiac biomarkers, and lipid panel, urinalysis, and thyroid function tests, which is particular to patients that are 65 years old and above. The CBC is completed, and as well as ABGs to help detect the presence of anemia or IDA and disturbance in the oxygen carrying capacity of blood cells. Levels of RBC, hemoglobin, and hematocrit will be low, and it will be verified by the presence of hypoxemia in the ABG. A CMP can check BUN and creatinine elevations and ALT elevations to determine renal and liver impairment due to decreased perfusion to these organs caused by heart failure. It can also assess electrolyte balance that may be altered due to fluid retention or metabolic dysfunction. Glucose levels are checked for the possibility of diabetes mellitus, which can amplify the complications. Cardiac biomarkers including BNP, troponin, and CKMB assess mortality risk and treatment efficacy, detect presence of heart attacks, myocardial damage, respectively. Lipid panels are tested to assess lipid profile and determine the possibility of coronary blockage. Urinalysis tests are performed to detect presence of protein, which is an early sign of decreased heart function and elevated specific gravity, indicative of decreased filtering capacity of the kidneys. Thyroid hormone levels are tested to assess the presence of hypo or hyperthyroidism, which may aggravate or cause heart failure in patients over 65 years old. Cardiac echogram with TEE, if needed, is considered the best tool in diagnosing heart failure. Cardiac valvular changes, pericardial effusion, chamber enlargement, ventricular hypertrophy, and determine ejection fraction, which is decreased with patients suffering from heart failure. Other diagnostic and monitoring procedures that Mr. Washington had gone through are chest X-ray to visualize heart and detect cardiomegaly, and assess degree of pulmonary congestion. EKG is also performed to assess ejection fraction and detect dysrhythmias. Treatment for CHF depends on symptomatic relief. Airway, breathing, and circulation needs to be addressed first. either by proper positioning techniques that allow optimal breathing, such as high Fowlers, and administration of oxygen. Medications such as diuretics assist in relieving excess fluid back up to reduce pulmonary congestion. Vasodilators such as nitroglycerin can be beneficial to reduce preload and afterload. Inotropic medications such as dobutamine can assist patients with signs of organ dysfunction in improving the pumping function of the heart and deliver blood to these organs. For appropriate patients, surgery can be proven to reduce morbidity. Depending on structural involvement, patient may obtain coronary vascularization or valvular replacements or any other kind of procedures. Risk factor modification can also augment the said treatments for Mr. Washington. Dietary changes can assist in preventing elevated lipids, blood sugar, and blood pressures by limiting or eliminating saturated fats, sugar, and sodium. Lifestyle changes can assist in weight management to prevent obesity. Cardiac rehabilitation assists patients in adhering to treatment plan via continuous monitoring. Gerontological considerations will need to be included to provide optimum patient-centered care. Utilizing the nursing process, assessment other than previously mentioned should include patient frailty, which can indicate the prognosis of the patient to treatments. Depression is also an observable occurrence with geriatric patients with heart failure. It is important to assess depression in the patient to determine medication compliance, ability for self-care, and quality of life. Cognitive dysfunction should be assessed to detect atherosclerotic risk factors such as hypertension, diabetes, and dyslipidemia. Psychosocial assessments can determine the patient's outlook towards treatment plans. The nursing diagnosis performed or allocated for the patient is decreased cardiac output related to alterations in rate, rhythm, electrical conduction, as evidenced by fluttering feeling in the chest. This is a sign of dysrhythmia, which is detrimental if left untreated. The next part is planning, implementation, and evaluation. Planning establishes a goal of adequate cardiac output as evidenced by absence of dysrhythmia. Implementation includes interventions that monitors the patient's cardiorespiratory status as well as administering prescribed medications. Evaluations expect to ensure Mr. Washington is hemodynamically stable with absent dysrhythmias. Special considerations are put up with patients in regards to medications to be taken at home. Use languages that are easier to understand and assess understanding by a teach-back method. So patient was receiving or was prescribed Lasix or furosemide, we could tell him that it is commonly known as a water pill, which helps remove excess fluids via urination. So he will need to use the restroom more often than usual to help lower his blood pressure and relieve breathing difficulties due to pulmonary congestion. We can tell the patient to rise up slowly before walking to prevent falls. We need to tell him to observe for rash and notify his physician immediately for possible side effects. And monitor for electrolyte imbalance symptoms such as diarrhea, headache, numbness, or tingling and blurry vision, and notify the physician. The other medication that he was prescribed was Capoten or captopril. It is an ACE inhibitor used to treat high blood pressure by relaxing blood vessels to improve blood flow and heart contractility. We'll need to tell the patient to avoid food that contains salt substitutes such as Mrs. Dash. And we can tell him that cough is an expected side effect, and if it gets too bothersome, we can contact the physician for possibly changing the medication. We need to also monitor for chest pain, facial swelling, and eye and lip swelling or difficulty of breathing because these are unwanted side effects and we need to call a doctor immediately. References: